My name is Shilpa Gurnodkar and I'm a pediatric endocrinologist at Nemours Children's Hospital in Orlando. Today I'm going to be talking about pediatric type 1 diabetes mellitus and focusing a little bit about the pathophysiology, but more so about the new technology such as insulin pumps and continuous glucose monitors. So as you all know, diabetes mellitus is one of the most common chronic diseases of childhood. Approximately 96,000 children under the age of 15 years are estimated to develop type 1 diabetes annually worldwide. The incidence is only increasing. There has been a 4.36% increase annually in children younger than 15 from the year 1995 to 2010. Type 2 diabetes is also on the rise, unfortunately, due to the obesity pandemic. Diagnosis of diabetes mellitus, there are certain criteria laid out by the American Diabetes Association. A fasting blood glucose over 126 milligrams per deciliter, typically times 2. A 2-hour postprandial blood glucose over 200 milligrams per deciliter, or a random blood glucose over 200 milligrams per deciliter with symptoms of hyperglycemia. Hemoglobin A1C alone for the diagnosis of diabetes is not very clear. However, a hemoglobin A1C over 6.5% should lead you to suspect diabetes. This is because hemoglobin levels vary in different kinds of anemias, and that also affects the hemoglobin A1C levels. Oral glucose tolerance test is an excellent test to diagnose type 2 diabetes and gestational diabetes, but is not recommended for diagnosing type 1 diabetes. So if I had to describe the pathophysiology of type 1 diabetes in one sentence, it would be environmental triggers in a genetically predisposed individual initiate the autoimmune destruction of the pancreatic beta cells. So the genetic risk factors are present from the time one is born. There are several HLA haplotypes that increase the risk and certain HLA haplotypes that actually decrease the risk of type 1 diabetes, but you're born with this. And at some point there is immune activation and immune response, and the body starts producing antibodies to the islet cells of the pancreas that produce insulin, and it may not be a long time before there is decreased insulin production by the pancreatic beta cells. Now, many studies have shown that when about 80 to 90% of the beta cell function is lost is when there is insulin deficiency and you start seeing hyperglycemia. As you all very well know, type 1 diabetes presents with increased thirst, which is polydipsia, polyuria, increased appetite. There can be weight loss, fatigue, weakness, increased risk of fungal infections. And if the hyperglycemia is persistent, there is formation of ketone bodies that results in nausea, vomiting, and eventually diabetic ketoacidosis. It may be hard to recognize in younger children because of lack of classic symptoms of diabetes. This is a really nice slide that translates what hemoglobin A1C levels mean in terms of glucose levels and risk of long-term complications. As you will see here, a hemoglobin A1C of 7% or less indicates excellent control of diabetes, and that is the hemoglobin A1C recommendation target A1C for both type 1 and type 2 diabetes set by the American Diabetes Association. The risk of long-term complications is also very low if your A1C is less than 7%. Once the hemoglobin A1C is greater than 7% or 8%, then that tremendously increases the risk of long-term complications. There's different types of insulins. The three commonly used ones are rapid-acting insulin, intermediate-acting insulin, and long-acting insulin. Rapid-acting insulins are typically taken before a meal because they start working in about 15 to 20 minutes after you take them. And then it peaks at about 1 to 2 hours and lasts in the body for approximately 4 hours. The intermediate insulins start acting at about 1 to 4 hours, peak at 6 to 12, and last for about 12 hours in the body. And the long-acting insulins really work in the body, stay in the body at the same dose for approximately 24 hours. So how do you administer insulin? It's always given subcutaneously, but there's two ways it can be done. You can either be on multiple daily injections, which can be a combination of intermediate-acting insulin and a rapid-acting insulin, or a combination of basal insulin with rapid-acting insulin. And the rapid-acting insulin may be given in the form of either carbohydrate ratios and correction factors for high blood sugars, or in the form of sliding scales. Doing carbohydrate ratios and correction factors is actually a better way of managing diabetes, because you're actually going to give the amount of insulin that's needed for what you're eating, and there is some more flexibility in what you can eat as opposed to sliding scales, which gives you a fixed dosage for your blood sugar. Another way of giving insulin is via an insulin pump. Now, these are the different types of insulin pumps that we have available and we use in pediatric patients. The one on the left here you'll see is the Omnipod. The Omnipod is a tubeless pump, and then it's about 2 inches long or so, and it has 2 parts in it. It has a little computer chip that responds to this controller device called PDM, and then it has a reservoir in which you fill up insulin. And then you have the pumps with the tubing, such as the Tandem T-Slim and the Medtronic 670G and other forms of Medtronic pump. And then there's a tube, and the very end of the tube has a tiny piece of fiber optic that goes under the skin, and it continuously gives insulin. So just a point about hyperglycemia in somebody who's using an insulin pump. Unlike multiple daily injections where you're on a basal insulin which stays in the body for 24 hours and you take insulin as needed for food or high blood sugars, there is no basal insulin in an insulin pump. All you're getting is the rapid acting insulin that you get as a basal rate every hour, and then you take more as needed for food or for high blood sugars, and therefore you're just getting insulin. And if you have a problem with the pump where the pump is not administering insulin, very quickly this patient can go into diabetic ketoacidosis. So if there is a patient who has hyperglycemia, an unexplained hyperglycemia times 2, and is on an insulin pump, you always check for urine ketones and then change the site of the pump right away and use an alternative method to give insulin, such as a syringe or an insulin pump, till the ketones are cleared and the glucose comes down, and then after that you start resuming the new pump site. Continuous glucose monitors or sensors have really been the breakthrough in technology with diabetes. So a continuous glucose monitor has a tiny little electrode end that is inserted subcutaneously, and it measures blood glucose levels in the interstitial fluid. We've gone from measuring glucose in the urine to plasma to capillary, which is the finger sticks, and now in the interstitial fluid. It is then connected to a transmitter that gives you a blood sugar reading approximately every 5 minutes. So you can get about 288 blood glucose readings in an entire day. Some examples of continuous glucose monitors. This is a DEXCOM, which is quite commonly used in pediatrics. On the left you have the DEXCOM G5, and on the right you have the DEXCOM G6. The G6 is the newest generation of DEXCOM, but a lot of patients are still using the G5, so you may see both of these in your practice. Both are approved for 2 years and up. For the G5, you calibrate it, which means you still check your blood sugar 2 times a day and enter it into the sensor to kind of calibrate it to your meter. With the G6, the company states that you don't have to calibrate it and you don't have to check your blood sugars anymore. However, we still have our patients check blood sugars if the number is very abnormal, very high or very low, or if the child is not feeling well, or if there is some sort of a discrepancy with the sensor readings. The G5 can be worn for 7 days, the G6 can be worn for a straight 10 days, so you just change it out every 10 days. And the other cool feature is that you can share it with different followers. So what you see here, the little white device here, this is the DEXCOM. The other end of it has a little fiber optic piece that is inserted under the skin, and then it transmits to this transmitter wirelessly. It gives you a blood glucose reading every 5 minutes. It gives you a graph next to it. You can scroll back and see what the numbers have been, but you can also share your readings with 5 different people or 5 different devices with the G5 and 10 different devices with the G6. So the parents can see the numbers, the grandparents, the teacher, the school nurse, and then so that also really improves the diabetes care. Also, you can set alarms for lows and highs in the sensor. Another really cool feature about the DEXCOM is that it has something called trend arrow. So you see an arrow next to the blood glucose, and it also tells you which way your glucose is going. So if it's an arrow sideways, it means your sugar has been stable over the last few readings, so it's going to stay stable, or it can give you a few arrows up or an arrow down, 2 arrows up, 2 arrows down. So it'll tell you how quickly your blood sugar is dropping or rising. These are some other sensors. The Guardian Sensor 3 is also used in pediatrics. The Freestyle Libre, and then the implantable sensor that stays in subcutaneously, a little tiny pellet subcutaneously, can stay there for 3 months. I would like to thank you for listening to my talk, and I hope you have some good points to take home to your practice.